We will speak about interpreting fetal heart rate pattern. This presentation is based on the NICE guidelines, which was published in February 2017, discussing fetal heart rate interpretation. Our learning objectives would be to know the indications of CTG, limitations and pitfalls, principles of interpretation, CTG interpretation, management of different patterns of CTG, and the value of intermittent auscultation. So if we start with the indications of CTG, we need to know why CTG is started in the first place, because this will affect our management. Definitely, if a CTG was started because of abnormal fetal heart rate during intermittent auscultation in a low-risk pregnancy, is completely different from a CTG started because of an IUGR baby. It's completely different from an IUGR baby with abnormal Dopplers or abnormal amniotic fluid. The action taken will be different based on the clinical picture. That's why it's very important to understand why CTG was initiated in the first place. In general, CTG is initiated due to any condition which can affect the blood supply going to the baby and in turn can affect the fetal well-being during labor. This can be either because of maternal side or fetal side or iatrogenic. Maternal side include group of disorders which affect the vasculature of the placenta, like hypertensive disease, in particular the preeclampsia, diabetes, especially type 2, which is complicated by vasculopathy, cardiac disorders, severe anemia, hemoglobinopathy, collagen vascular disease, and renal disease. These all disorders share common finding, which is reduction of blood supply going to the fetus. On the other side is that baby. So in multiple pregnancies, we know that multiple pregnancies has its own complications, especially twin transfusion syndrome and twin reverse arterial perfusion and others. So these multiple pregnancies actually, because of their unique nature, require fetal monitoring because babies are most likely to be affected during labor. Intrauterine growth restriction. These babies are already affected during the antenatal care and more prone to hypoxia because of low oxygen reserve, usually unable to tolerate the stress of labor. That's why CTG is of particular importance in this group of babies in order to improve the outcome. Preterm birth, breech, and RH isoimmunization. RH isoimmunization, babies affected by RH incompatibility are more likely to develop fetal anemia. That's why they have their own antenatal care by monitoring of the middle cerebral artery Doppler, and may sometimes require intrauterine transfusion and early delivery. And again, because of that, they are more liable for complications during labor, and that's why TG is indicated in these group of patients. Then we come to the iatrogenic causes, in which there is no lesion in the mom or in the baby, but there are intrapartum factors, iatrogenic, occurred because of the doctor or the obstetrician handling labor, like induction of labor and augmentation. And the reason behind that is induction or augmentation can cause uterine hyperstimulation, which is excessive uterine contractions, which can cause compression and accordingly affect the blood flow going to baby. Prolonged labor, and think about it, prolonged labor, if I ask you to run forever, usually your capacity is able to run for 1 mile and you are maintaining your fitness, but if I ask you to run forever, then I tell you to stop. At a certain point you will feel tired, and if you continue to run waiting for my order to stop, you may collapse. The same thing with the baby. That's why we have these parameters in labor, that in first stage of labor, the progress of labor should be 2 centimeters every 4 hours, roughly, and for second stage it should last between 2 to 3 hours depending on primer or multiple, with or without visual anesthesia. That's why if labor is prolonged, it carries risk of fetal affection, and that's why CTG is indicated. Regional analgesia. Regional analgesia can be due to multiple factors, but the most common is hypotension. As epidural can cause vasodilatation. Vasodilatation can result in either clinically significant hypotension in the mom, which will affect the baby, or vasodilatation of the placental vasculature, which will mean that send drop in blood pressure as well inside, and accordingly, baby will be affected. We notice it more commonly after epidural that there are a bit of transient bradycardia, maybe, or decelerations, and TG improve with intravenous fluid. Abnormal uterine activity, particulate meconium, because meconium, passage of meconium is either due to post-maturity or hypoxia. Because hypoxia can cause relaxation of the sphincters, so hypoxia means that babies are already affected, and if babies are affected, CTG is indicated. Abnormal fetal heart rate upon admission. So if the woman firstly presenting to labor ward and has her admission CTG, as some units do, or intermittent auscultation and we found abnormal fetal heart rate, here CTG is indicated, but CTG is indicated for a period of time between 20 and 30 minutes, and if CTG become normal, in this case we can stop it. And definitely any cause of vaginal bleeding in labor. So in summary, the indication of CTG are anything outside normal. This can be either abnormality in the mom, vital signs like tachycardia, high temperature, or are affecting infection, if abdominal pain other than the contractions, bleeding, meconium, as we said before, hypertension and preeclampsia, hyperstimulation, prolonged labor, augmentation, or fetal heart rate abnormality. So just summarize the indications, anything outside the normal or low risk pregnancy will require CTG. But unfortunately, CTG is not the magic stick. So doing a CTG doesn't mean that you are protecting the baby. Unfortunately, there are a lot of failures, either due to you fail to perform CTG when there's a valid indication, or you fail to ensure good quality tracing. And by good quality tracing, there are certain prerequisites which we'll discuss in order to do CTG, in order for tracing to be of good quality. So if you didn't follow these good quality measures, you actually can lead to complications. Failure to recognize the fetal heart. So you recognize that this case CTG is indicated. You ensure you have good quality, but you didn't have the proper training for CTG interpretation. So you didn't know what is the CTG. Or you know what is the CTG, but you don't know what to do. So you fail to act appropriately when the fetal heart rate is abnormal. Or you decided that this patient required immediate delivery because of abnormal CTG, but unfortunately there was a delay in expediting this delivery, either due to wrongly categorizing the cesarean section. For example, she needs Cat 1 cesarean section, you make it as category 2, or there was any delay in system, either transfer to theater, presence of anesthesia, etc., etc. So what are the prerequisites of CTG, or how to ensure good quality CTG? First, identify the fetal heart. Second, you have to document all the patient identifiable information and the date and time of recording CTG, gestational age, clinical picture, and make sure the speed of the paper. The CTG is a medical document, and it will stay in the file of the patient for quite a long time, up to 21 years, because the patient has the right to claim at any time before that. Therefore, you have to maintain a good quality documentation of this paper. During monitoring, you have to monitor the maternal pulse to make sure that you are not recording the maternal pulse as if it is the fetal heart rate. And you have a couple of instances where CTG looks brilliant, but actually baby was dead. This is because CTG is recording the maternal heart, which was tachycardic now. Good quality tracing, so make sure that the CTG is recording, which means that if there's any poor contact, especially in obese mom or patient with continuous movement due to pain, and you can't have a good quality tracing, in this case think about fetal scapular fluid, fresh eyes, and should be every hour. And by fresh eyes we mean that another person outside the room who has the capacity for CTG interpretation come inside, review CTG, and make sure that he has the same opinion as the person in the room, providing one-to-one care. Document any key events, like if you had tensioner augmentation, if you had epidural or amniotomy, because these key events will again add to the clinical picture of the patient. And once you see the GDG, please sign it and write your opinion and document in the notes. Again, it's a medical legal document which requires proper documentation. And when the patient delivers, you need to make a straight line right in its end, and the midwife should sign it. Basics of CDG interpretation is Dr. C. BRAVADO, which is the mnemonic, which refers to doctor as terminal risk, which is the clinical picture. C is the contractions. P, baseline rate. V, variability, acceleration, deceleration, overall assessment. It's nice mnemonic to remember what are the key elements you would like to interpret in CTG. First, which is determined risk, which is the maternal risk factor, fetal risk factor, intrapartum risk factor, and the progressive labor, as we discussed before. As you can see here, I get you a snapshot of a piece of CTG, which will show what we mean by baseline rate. So baseline rate is roughly any line which can go through the oscillations of CTG, maintaining its presence throughout the segment, is called the baseline. So we don't use the acceleration as a baseline, we don't use the deceleration as a baseline. This line should pass through the oscillations also. Then as you see the accelerations, which is any increase in the fetal heart rate. Then the variability, deceleration, which is any decrease in the fetal heart rate, and the lower line is the contractions. If we start with the contractions, contractions can be detected either by the old methods, which are palpation, or by the external transducer, which we call it probe of CTG, which is the most commonly now used, or the intrauterine pressure monitoring, which is no more used for the risk of infection and the age of the fetus, and the studies found that it had no value with the external monitoring. Contractions usually should be 3 to 5 in 10 minutes. If there's more than 5, it's called tachycardia, and more than 5 is more likely to affect the baby and the fetal heart rate pattern. That's why once the contraction is starting to be more than 5, you have to think about how to review these contractions, and one of them is to stop the augmenting agent if you are using oxytocin, for example. For the baseline rate, and as you can see in this segment, as I discussed before, it is a line which you can pass, it's an imaginary line which can pass through the oscillations of CTG, avoiding any areas of acceleration or deceleration. Then we have certain numbers which we need to know by heart, because these numbers affect our interpretation of CTG. So we have reassuring baseline, which is any value between 110 to 160. We have a non-reassuring, which is any value between 100 to 109, or 161, 180. However, if it is 100 to 109, but all other features are normal, in this case we don't need to act, we don't do anything, just continue observation. And abnormal, which is any heart rate less than 100 or more than 180. However, you need to take care about what was the baseline before the time you are interpreting CTG. That's why CTG is just a paper, and don't interpret based on the piece of paper in front of you. In other words, don't take a snapshot of the time. You have to interpret from the previous or from the start of CTG monitoring. Because we have a rising baseline or a dropping baseline, which is very serious and can be missed easily. For example, baby can start at heart rate 120, 130, and then the midwife called you to interpret CTG at 2 hours later, and you find 140 or 150. It's still within the number is reassuring, but if you compare it to start baseline, it's a rising baseline, which can notify an early onset infection. So you have to take care about what was happening before the time you are coming to interpret CTG. Another area of importance is the difference between stable baseline and wandering baseline. Please, wandering baseline is not a normal baseline, yet you don't need to act, you don't need to deliver now. However, you need to be closely observing this baby. Because ask yourself why this baby is hyperactive, why this baby is not resting, why he is not following the pattern. I usually say that babies are very smart inside the womb, inside the uterus, and they are always whispering and send us messages. These messages can be detected by CTG, so you have to be careful in getting out these messages, because your interpretation will affect the fetal well-being and the baby health after that. So wandering baseline is not normal, yet we need to act. However, you need to be closely observing this baby and see and ask yourself why this happened. Tachycardia is fight or flight stress response. So if the baby is exposed to stress, especially infection or fetal maternal hemorrhage or any stress in labor, fetal heart rate starts to rise, which we call it fight or flight. However, baseline can rise for any other reason. So a rising baseline rate even with normal range may be of concern. That's why I'm saying you don't interpret CTG based on a snapshot. Don't take just segments which the midwife is concerned. You have to look at the previous segment. What was CTG like? Is the baseline rises? Is it dropping? You have to make a correlation between the start of the CTG and what's happening now. So what is variability? Variability is the fluctuations in the fetal heart rate in amplitude and frequency. In simple terms, this is the oscillations which you can see in CTG tracing. We have two types of variability. We have short term, we have long term. And variability indicates an intact nervous system because variability is the interaction between sympathetic and the parasympathetic. And as long as the baby is maintaining normal variability, this means that the nervous system is intact and the baby is healthy. Variability, I can consider is the most important parameter in CTG. We have certain figures which are reassuring between 5 to 25 beats per minute. It's not reassuring if less than 5 beats per minute for 50 minutes, or more than 25 beats per minute for 30 minutes. It's abnormal if less than 5 beats per minute for more than 50 minutes, or more than 25 beats per minute for more than 30 minutes, or sinusoidal. And why the 50 minutes interval come? Because babies are allowed to sleep. There's something called fetal sleep cycle. So as you see here in the segment of CTG, in the line number 8, there's a brilliant oscillations in CTG, which provides this baby has very good variability, has intact nervous system, healthy baby. Line number B denotes fetal movement. Some CTGs have the proof of fetal movement in which the mom will start recording fetal movement, especially during moves. Here you can see two different patterns of variability. So the one on your left side is an absent or reduced variability, in which you can see the line is almost a flat line. This is what I mean by reduced or absent variability. If you compare it to the one which was in the slide in the previous slide, you can see the oscillations were coming up and down, fluctuating with fetal heart rate, which is the interaction between sympathetic and the parasympathetic, as I said before. Here the fetal heart rate is almost a flat line, which denotes that baby is hypoxic. And on your right side is a sinusoidal pattern, which denotes fetal maternal hemorrhage, which denotes fetal anemia. As you can see, there is no fluctuation, it's just fixed amplitude, fixed frequency, as if you are doing a T-so-T appearance, which is characteristic of fetal anemia, and it is a serious CTG pattern, which requires immediate action. So what is the etiology of reduced variability? What's happening? You need to understand what's happening in order to start correcting, because reduced variability is a serious sign, but again, doesn't mean that you have to deliver now. However, you need to correct the underlying factor. So the first one, which is the sleep quiet phase, which is normal. That's why we said that if reduced variability up to 50 minutes can be normal. Hypoxia, prematurity, tachycardia, drugs, especially betamethasone, anticholinergic, magnesium sulfate, and narcotic. That's why most women who receive steroids in threaten the preterm labor, and you don't act near the CTG, you will find reduced variability. Here you know the reason. You know it will cause reduced variability for a certain time, so you don't need to act now, but you need to observe. And again, in labor, the most common drug we use is Deceleration, and once we give the Deceleration, the fetal heart rate starts to show reduced variability. Again, you know the reason, you know baby is okay, so you need to act now, but you need to keep observing. Any congenital malformation in central nervous system, cardiac arrhythmias, fetal anemia, which will cause sinusoidal pattern and fetal infection. So this is what we call the cyclic pattern. As you can see, there are periods of good variability, then area of reduced variability, then area of good variability. This is normal CTG. Actually, we like to see this cyclic pattern, because you know the baby is active sleeping, so the baby is normal. The sinusoidal pattern which we saw before, it occurs usually with fetal anemia and sometimes acute hypoxia, in which the beat-to-beat variability is absent, as you saw before, you just see slow disappearance. So you have regular oscillations as sine wave. It lasts about at least 10 minutes and has fixed period of 3 to 5 cycles per minute, and the amplitude is usually between 5 to 15 beats per minute above or below the baseline. So it's fixed. There is no change in the character, and the most important is absence of acceleration. However, there's another pathology called pseudosinusoidal, and pseudosinusoidal usually happen due to some cycling or narcotic administration and is not serious. You don't need to require delivery. And in pseudosinusoidal, you will find some accelerations. It is the only difference between sinusoidal and pseudosinusoidal. As you can see here, CTG on your left hand side is sinusoidal pattern again. So this regular oscillation, like CSOT appearance. There is no variability in these oscillations. A fixed amplitude, a fixed rate above and below the baseline, which is 5 to 15 beats per minute. But in your left hand side, although it looks a bit similar, but as you can see, there's some sort of a change in the baseline in these oscillations in the form of a bit of acceleration, and then it follows the same amplitude also. So we call it pseudosinusoidal, and it's usually transient and usually improve once the causing factor is off, like some cycling or the narcotic trigger. Accelerations is any increase in the fetal heart rate for more than 15 beats per minute for more than 15 seconds. So for an acceleration to be an acceleration, it should be more than 15 beats per minute for a period of more than 15 seconds and no deceleration after that. Presence of acceleration even with reduced variability is sign the baby is healthy. So if you see the acceleration in the intrapartum CTG, it's a reassuring sign. However, its absence is still a normal CTG. So if you see a CTG intrapartum and you can't find an acceleration, it still can be a normal CTG. But please, it's different from an antenatal CTG. So if acceleration in antenatal CTG is a must, you need to see an acceleration in response to fetal movement in antenatal CTG. But an intrapartum is not a must. Deceleration is opposite to acceleration. So it is decreasing fetal heart rate by 15 beats per minute for more than 15 seconds. And depends on the correlation of the contraction, can be early, late, and variable. And it's prolonged if more than 2 minutes. And if it's 10 minutes or more, it actually changes the baseline. So here is the early deceleration, which is a mirror image of the contraction. You can see here the start of the deceleration is coinciding with the start of the contraction. The nadir of deceleration is coinciding with the peak of the contraction, and then the recovery of deceleration is coinciding with the disappearance of contraction or the end of contraction. Early deceleration are benign, because they are related to head compression due to vagal stimulation, which lead to parasympathetic stimulation, but they are not common at women labor, so they are rare. So please, before saying it's an early deceleration, you need to be sure if you are really classified as an early and follow the OR criteria, which is nice U-shape, gradual decrease, gradual return, and a mirror image of the contraction. For late deceleration, in the case of the fetal heart rate, there is a bit of a lag between this decrease and the peak of contraction. The start of deceleration actually coincides with the peak of the contraction, and then the nadir of deceleration is coinciding with the end of contraction, and then the baby will recover after that. Late deceleration occurs due to uteroplacental insufficiency, which means that there is not enough oxygen stored inside the baby. That's why it's late, that's why there's a lag. What's happening is, the start of the uterine contraction represents stress on the baby. So baby is trying to use his resources in order to cope with the stress, but the resources are not enough. So these resources can't help baby to cope with the whole time of contraction. So at the first part of it, he was coping well, but then he has no resources. So the fetal heart rate starts to drop dramatically, causing the nadir of deceleration. And then the stress is over, so the fetal heart rate will rebuild again stores and turn back to normal. For variable deceleration, these are an abrupt decrease in fetal heart rate, which we call it the V-shape, in which there is rapid drop and rapid return. They have no relation to the contraction, and the immunity to cord compression. These variables actually have different classifications. They can be as typical or atypical, or classified as variable without concerning features and variable with concerning features as the recent NICE classification. And they start to be concerning if there is an absent variability or a prolonged bradycardia, as we will see later. So when you see a deceleration, the first thing you need to correlate with contraction to know is it early or late or variable. The second thing you need to ask yourself, is it a V or a U? So V is the rapid drop and rapid recovery, and there's a good variability within deceleration. All other features are normal. If it happens, it's still not associated with hypoxia, because as we will see later in the classification, these V's can continue forever, and the maximum is non-reassuring feature, and you need to do anything for that. And most likely due to bilateral stimulation. But for the U, is a gradual drop and a gradual return. The U can be either early or late. Late means that the fetal hypoxia and the chemoradical stimulation. We spoke about the variable deceleration or the V shape, and we said they are either typical or atypical, or concerning and non-concerning features. So what are the concerning features? When I should worry when I have V? Because it before, the V are okay. The V, the maximum is non-reassuring feature, which means I don't need to do anything if other features are normal. But when I start to be concerned, if you have any of these 5 characteristics inside the V, you have to be concerned and you have to think about the management immediately. First, if it is more than 60 seconds. So if the drop in fetal heart rate lasts for a duration of more than 60 seconds, and you can see in the second figure on the top. Reduced baseline variability in deceleration. As you can see in all these figures, there is no oscillation actually. So the variability is just a straight line down and then a straight line up. If it is like that, it's a concerning feature. However, if there is some oscillations within these decelerations, so the BB is okay. But once these oscillations disappear, which means that there is no variability or reduced variability, this BB is not okay. Or failure to return the baseline. So for example, baseline before deceleration was 140 to 150, then deceleration happened, and then BB never returned back to this baseline. This means the BB is affected because the stalls are not enough to return the heart rate to the normal baseline before. Or biphasic. Biphasic means that, like in figure 1, so BB wants to recover, but he can't because there's no enough stalls, so he drop again. This means the BB is hypoxic and suffering. Or no shouldering, especially if it was present before. So sometimes deceleration is associated with shouldering either before or after the deceleration, which means that sudden acceleration after the deceleration. If this shouldering disappeared after its presence, it's a concerning feature. However, if there was no shouldering from the start of CTG, so it is okay. So here you have to differentiate. Is this shouldering absent from the start, or there was shouldering and then it disappeared? If there was shouldering and then it disappeared, this means that deceleration starts to be a concerning. However, if there is no shouldering from the start, this means that you can ignore this feature. So what will be the classification of CTG? It's either normal, when all features are reassuring, or suspicious, when one is non-reassuring feature and two reassuring features, and pathological if there is one abnormal feature or two non-reassuring features, and you have need for urgent intervention like case of acute bradycardia, single prolonged deceleration for 3 minutes or more. So for the management, if you have a normal CTG, then you can continue. No need to do any action, except if CTG was started before because of concern arising from intermittent auscultation. As I said before, there is the importance of knowing why CTG was initiated. So if CTG was initiated because there was an abnormality in fetal heart rate during intermittent auscultation, and then CTG become normal for 20 to 30 minutes, then the patient can return back to intermittent auscultation and there is no need to continuously monitor the fetal heart. and then you have to inform the woman and her birth companion about what's happening. Remember, communication is very important. However, if you have a suspicious CTG, you need to correct any underlying cause first, like hypotension or uterine hyperstimulation. You need to perform a full set of observations: temperature, heart rate, blood pressure, respiratory rate, and then start one or more of these conservative measures, which are eye fluid, left lateral position, because this will help to improve the blood supply to the baby, and accordingly can help to improve the fetal heart rate. If there is uterine hyperstimulation, you need to stop or reduce the symptom or remove the purpose. You can give tipidaline, which is tocolytic agent, and given a dose of 0.25 milligrams subcutaneous. You need to inform the obstetrician, or for the midwife, you need to inform the senior midwife, and then document the plan. Because you have severe CTG, you don't need to deliver now, but you need to be closely observing the baby. So based on what feature is normally assuring, you need to write your plan about the review. When do you want to review the CTG again? After 20 minutes, after 30 minutes, after 10 minutes, based on the finding which is normally assuring for you to classify TG as suspicious, and again communicate with the woman and her birth company. If you have a pathological CTG, still you need to do the same measures as before, but you need to exclude the acute events. And we have 3 acute events: cord prolapse, placental abruption, and uterine rupture. If you have any suspicions of any of these 3, or confirmed diagnosis, you need to have urgent delivery. You need to correct the underlying cause, as we said before, like hypotension or uterine stimulation. Again, start the conservative measures as before. You have to communicate again. However, this TG is abnormal, so you need to take an action. If these conservative measures didn't correct CTG, you have to do an action. This action will start first by digital scalp stimulation. So while you're examining the woman vaginally, you stimulate the fetal scalp. Usually if the baby is healthy, this stimulation will lead to acceleration, so this is reassuring. If it happens, it's reassuring. You need to document that. So you'll write fetal scalp stimulation, positive, fetal heart rate acceleration, and then you'll write your plan about what you need to do after that. However, if you had the fetal scalp stimulation and the fetal is not responding, no acceleration, this means the baby is not healthy. For CTG which require urgent intervention, as said before, a bradycardia or a prolonged deceleration for more than 3 minutes. In this case, you need to seek urgent obstetric help. Again, exclude acute events. You have to correct any underlying cause and again start the conservative measures, but you have to make preparation for an urgent birth. Don't forget communication. If bradycardia persists for more than 9 minutes, baby should come out, and then we'll go to the rule of 3, 6, 9, and 12. Here we come to the rule of 3, 6, 9, 12, and 15 minutes. This rule is very important because it puts a time frame of how to deal with acute events, which is acute bradycardia. So for the first 3 minutes, you call for help. For 6 minutes, you need to identify the cause and you do your intervention to improve oxygenation, like left lateral position, IV fluid, stop syncynon, and give tipidaline 0.25 mg subcutaneous. If CTG is still not improving, you have to move to theater to prepare for delivery. But here by 9 minutes, you have to reconsider your decision again, because 95% of CTG will improve by 9 minutes by the measures you did, and there will be no need to expose the mom to a risk of category 1 cesarean section under general anesthetic. That's why it's very important to look and think at this 9-minute interval. Am I still need to go for urgent delivery, category 1 cesarean section, or I can wait? If CTG improve, then you can wait. You can wait even in theater for 15 minutes, 20 minutes and see what's happening. If CTG continues to be normal, the patient can return back to her maternity room and continue to deliver as before. If not improving, then you can decide to deliver. Or even you can recategorize your cesarean section from category 1 to category 2. So please, at 9 minutes, you have to think about the situation again. If no improvement, by 12 minutes you need to prepare for delivery, and baby should be out by 15 minutes. We all know that time frame for category 1 cesarean section is 30 minutes, and this is for maternal safety, because you shouldn't compromise maternal safety at any cost. But we know as well that after 15 minutes of prolonged hypoxia, baby will start to suffer. Please don't follow the 3-minute rule if the sedation is preceded by reduced variability and lack of cycling. So if CTG is obvious that it's an abnormal and then start having a bradycardia, you need to think about delivery urgent. Don't wait. This rule of 3, 6, 9, 12, 15 minutes only apply in case of an acute bradycardia for 3 minutes, but CTG before that is completely normal. And finally, this is the ticker which we use in all our hospitals, which shows different parameters of CTG interpretation and different features which is put before the classification between reassuring, non-reassuring, and pathological feature, baseline rate, variability, acceleration, deceleration, what are the concerning features in deceleration. We always encourage to use this sticker because you don't need to depend on your memory about the numbers, especially early morning time or late midnight when you're retired seeing a lot of patients. So looking at the sticker will help you to make the proper classification, proper interpretation, and the proper classification of CDG. Also, it will remind you with the management plan if it is reassuring, so it's continuous CDG, normal care. If suspicious, you will correct the measures and you will start the conservative measures. If you have anticipation and if it's pathological, what you will do, you have to sign and refresh eyes. So we always recommend using stickers for easy and safe CDG interpretation. Thank you for your time. If you like this presentation, please subscribe to our channel so you can get more videos. Thank you. Muhammad al